Well, good morning. We're going to go over a hormone zoomer today. And let me bring that up. Okay, so we have the hormone zoomer up here. This is a demo. The demographics are here and whatever. This is the testing that was done. A little bit of an introduction here, the methodologies, interpretation of the report, a little bit of information here. Now, this lab, people always want to know, gee, is this a reputable lab? Well, not only CLIA certified, as mentioned here, but they're also American, they're CAP certified. That's the College of Pathology. So every so often they get blind samples that they have to run, and they have to be within a certain percentage of the known sample results, and they don't know what it is. They just have to run it and figure it out. So this is a lab that's certified at the highest level. So Hormone Zoomer summary. So the summary is really all the relevant highs and lows. And it starts with the questionnaire data. Now, this is all stuff that you should know from the patient's history, but it's nice to have it here to remind you as you're thinking about the hormone results. I mentioned in other videos that I'm not a big fan of just willy-nilly giving people hormones. So you look at a test like this and you go, oh, look, their pregnenolone is low. Let's give them some pregnenolone, and their estrogen is high, and let's do something about that, and this and that, and all these isolated ideas. I'm not a big fan of that, and I'll show you why in this demo. So this is a woman, female. They have norms for males as well. She is postmenopausal. She is having no menstrual cycles. She has not had a hysterectomy. Her last menstrual period, she doesn't state. She has had a bone density scan, and she has osteoporosis. She has not experienced a fracture. She does not have any known toxic exposures. She is not having hot flashes, mood swings. She does have severe fatigue, no vaginal dryness, sleep disturbances, none, moderate joint pain, no loss of libido, moderate muscular loss, no difficulty with concentrating, and no urinary problems. So medical history, all no's, and NA, any cancer is not listed above. She apparently doesn't. Cardiovascular disease, yes. Oh, well, that's something we need to think about in the context of hormones. All of these things are no until we get down here to some obesity, and we'll see later that there's other markers suggesting some insulin resistance and so on. And then clots. She's had some clots. We don't know if from this, we don't know if it's just a venous clot. Could be a venous clot below the knee, which is not as serious, but could be something more serious. So there's clotting. So we have to think about that in the context of hormones. Breast cancer in the family, thyroid disease in the family. Hormone treatment preferred. She'd like to be on HRT. Skin sensitivities, no. Peanut allergy, becomes some HRTs are in peanut oil. Undergoing HRT, she says no here, but then right here she talks about the hormones she's on. And this is, you see this all the time, right? People, it says undergoing HRT. Well, I don't know what HRT stands for, so no. Am I taking hormones? Oh, yeah, I am. Okay, so that's the context in which we're thinking about this test. So the first thing we're going to look at is the stress responses. So it's not just me and Elizabeth who are thinking that stress is a big deal, right? Even the labs think that. I want to just point that out. All right, so this gives us a little picture here. Hypothalamus communicates with the pituitary, communicates with the adrenal glands, which releases cortisol. Circulating free cortisol, well, here's the free cortisol pattern. It's high in the morning, but otherwise normal. But the cortisone pattern is different from that. And these are salivary. So these are the free hormones. Whenever you see salivary hormone, you're talking about free hormone, not bound hormone. So then we can move back and forth between these things as we need, and the ratio here is high. Total cortisol is higher than cortisol. So we're already thinking about this person's under probably a lot of stress. Now, this is the tabular form of what we just saw graphically. So here's that AM high cortisol. Everything else was normal. Here are the normal morning cortisones and the high evening. And what they do on this test is they have you take wake plus 30 minutes, wake plus 60 minutes, evening, night. And then if you wake up in the middle of the night, an insomnia test, then they take a total as well. So then the educational part, everything that's abnormal on this test is in the comments. So salivary cortisol evening is high. Salivary cortisol night is high. Total is high. Insomnia is high. And it talks about what it means. So, how do you become an expert at these things? You read this stuff, and then you look up the relevant biochemistry to understand how this is all interconnected. And so, this idea that you just look at the numbers and, oh, well, the estrogen is low, so I'm going to give some estrogen. No, you have to understand the interrelational network. But there are some supportive supplement suggestions, right? Some licorice, some melatonin. Why melatonin when the melatonin, as we'll see in a minute, is already high? Well, because this is a one-off recommendation based on one abnormality, not looking at the test as a whole. And then some yoga or other meditative practices are also recommended. Now, adrenal hormones. Well, the first, we're talking about the pineal gland to start with. Pineal gland is melatonin. And morning melatonin is really high, and then it rapidly drops into the normal range and stays there. So what's going on with this? Melatonin 6S represents sort of overnight melatonin manufacture and circulation. And this represents either very high overnight numbers or delayed shutoff, and more likely delayed shutoff. Then we got hypothalamus pituitary adrenal glands again, making DHEA the dominant androgen in women. And it's normal. And then cortisol can be metabolized to here. And then we look at the cortisol-cortisone ratio. It's actually normal here. And then the urinary. So this is different than salivary that we were looking at. And our salivary cortisols and cortisones are almost all normal. One's abnormal. So down here, we're seeing adrenal hormones. And we see this is slightly low, DHEA, all of these were normal. So then here's this commentary on the abnormality. And it talks about this stuff. So then it gives us some suggestions, some vitamin E, some NAC. NAC, of course, a precursor to glutathione. And glutathione is one of the ways. Is that up here? No, it's down lower. NAC and glutathione are one of the ways in which some of these hormones are detoxified. Then, again, the diurnal cortisone from a urinary perspective, the nighttime was high. It talks about the free night cortisol and things we might do about that. But again, looking at these in isolation is not the way to do it. We need to think about that free cortisol and why. The functional medicine question is always why, right? So free cortisol at night is high. Why is that? Is there a circadian issue here? Is she staying up late at night watching TV until 2 a.m.? Is she just really stressing out at night, thinking about the day and tomorrow and whatever else? We have to think about those questions. So again, lots of data on this test. And again, this is the tabular representation of what we already saw on the graphic. So here is the melatonin first thing in the morning was really high, but it rapidly drops into the normal range. And this suggests a delay. So the evening is still in the normal range, but see how it dropped, it came down in the middle of the normal range, and now it's ramping back up. And if we did, a little later on, we'd see it just ramping until it's way up here. And so we're seeing a delayed shutoff of melatonin. And this might be compensatory, right? Because melatonin is a great antioxidant. And we know that she's got a couple of inflammatory problems. She's got some metabolic syndrome. She's got some coronary artery disease. And she appears to have stress. So this might be compensating, a compensatory mechanism for that. It might be a stress response and a delayed shutoff of melatonin. So we have to be thinking about this deeper than just, oh, it's high. So here, supplement suggestion. Here's an interesting one, caffeine. Caffeine is metabolized in the liver by cytochrome CYP1A2, which also metabolizes melatonin. By competing for this enzyme, caffeine reduces melatonin breakdown, leading to higher nighttime melatonin levels. So if you look at this supplement suggestion, take caffeine, well, it's already high. Why are they telling us to do this? So you need to be careful when you're really reading some of these things. Do we really want her melatonin to be higher? Because if we're competing here, it might actually make it higher yet. So we need to be careful there. Okay, so now we're looking at sex hormones. These are urinary sex hormones. So pregnenolone is sort of the ready reserve hormone. Pregnenolone can be turned into progesterone. And then progesterone can be metabolized either by 5-alpha reductase or 5-beta reductase, and become these two things. And these are measured as normal. And then we care about that because we want to know about the 5-alpha dominance. And in this case, dominance would be a high number. So this is not 5-alpha dominant. And then pregnenolone can become DHEA. DHEA is measured as DHA sulfate, which is normal. But these other things are measured as well. So here's again that 5-alpha reductase, 5-beta reductase, and they make these other things. So this is where we're looking at this ratio. And then you can also make from pregnenolone through DHEA through this over to testosterone. And then testosterone can be aromatase to estradiol, the most dominant estrogen. And this is why elderly men who have an excess of aromatase feminize. They get loss of facial hair, they get breast enlargement and things like that. It can also go through aromatase from here into E1. Now, in the old days, we used to have triest, and we would give E1, E2, and E3. We now believe that E3 is primarily a detoxification product. And so most of us don't use triest anymore. We use biest. And you can get that in either a 80-20 mix, 80-20, or a 50-50 mix. Those are the two most common. But then we have to worry about how is this stuff being detoxified. So it's being detoxified by a number of routes. One of the routes is 16-hydroxy-E1 through CA4, CYP-CA4. So this 16-hydroxy estradiol or estrone is the preferred way to detoxify. 4-hydroxyestrone, if not properly quenched through glutathione detoxification, can interact with DNA and damage DNA, which we don't want. And then there's also 2-hydroxyestrone, which is a better way to detoxify. Now, in this person's case, they have a dominance of 4-hydroxy-E1 detoxification. It's quite dominant, as you can see here. So we have to be very worried about this. We have to make sure that we have adequate support for glutathione, because we need to go this way and not this way. So we have to, this is another reason to be cautious in this individual about hormone replacement therapy. So estrogens, okay, well, we've got some high estrogens and so on. We've already seen those in the graphics, but this is the tabular form. And so then we get the commentary. So it talks about E1, talks about 2-hydroxy, talks about 4-hydroxy. And then there's a little bit commentary about these other things and some commentary about some ideas here. So anytime you're seeing soy isoflavones, or those kinds of things, you're really talking about competition. So whether it's genistein, which I call a phyto-SERM. SERM stands for selective estrogen receptor modulator. So these are acting as receptor modulators. They basically sit on top of the receptor and block the more powerful estrogens from stimulating that receptor and normalizing or downregulating, in the case of too much estrogen, downregulating estrogenic activity. And in the case of too little estrogen, they can actually upregulate estrogen activity. So in a sense, these things are adaptogenic. Now, the other thing we're talking about here, the 4-hydroxy estradiol, estriol. Well, it does say estradiol. Anyway, this isoflavone, such as genistein, inhibit the activity of the aromatase. And so we're using it therapeutically to try to modulate that. The other thing that helps with this is DIM and those kinds of things. So, and then they talk about vitamin D. So now we're on to the progesterone category, and these are all pretty normal. So if you have high estrogens and low progesterone, you have this estrogen dominance pattern. But as I talked about in another video, you can have estrogen dominance because the estrogen is high, but you could also have estrogen dominance because progesterone is low. In this person's case, it's because estrogen is high, so our focus needs to be not on raising progesterone, but in detoxifying estrogens. So again, it's not just about, oh, give more. Testosterone, we already saw these graphically, but here are all the numbers in this 5-alpha, 3-alpha stuff here is high. So it talks about it here. What is it? It's an androgen metabolite of testosterone and so on. And we care about it because it's found in perimenopausal women with hirsutism. So we want to understand how to manage it. Chromium picolinate. Well, why? Because it helps with glucose metabolism and insulin sensitivity. So we keep talking about its networks, right? We're talking about helping the androgens by managing insulin sensitivity, calcium and vitamin D signaling, melatonin signaling. So we're thinking about this as a network, not as a simple, this does that. And then hormone ratios. Here's the ratio of, excuse me, I am going to sneeze. Maybe not. Okay. Here's the ratios of the estrogens, some of the hydroxylated, so the 2-hydroxy and 16-hydroxy, and then 2 and 4, and so on. So we're getting a sense of how these things relate to each other. More ratios, lots of ratios. And then it talks about all the ratios here. So again, a learning opportunity, talks about some supplementation to normalize some of those ratios and why, right? And why, and that's the important thing. That's always the functional question, is why. Now we're looking at oxidative stress markers because again, it's a network. So 8-hydroxy 2-deoxyguanosine, or 8-hydroxy-DG, is an oxidative stress product of DNA. So it's not elevated here, but if it was, we'd be particularly worried about that DNA damage stuff, right? And then all the creatinines are normal. This is just how they make sure that the concentration of the urine is within a limit that they can do the calculations for all the values. And then we look at endocrine disruptors. So atrazine, pretty elevated. So atrazine and many of these things are hormone disruptors, right? And the way hormone disruptors work is in a bunch of different places. It can either work from the transcription from DNA to RNA or the translation from RNA to the hormone. So it can work in any of these places. So if this is really high, I would be starting there. I would be thinking about detox before I started hormone replacement. And what does detox entail? Well, it entails making sure the excretion pathways are good. So you're talking about a 5R program to restore gut health. You're talking about hydration. You're talking about, optimizing phase 1 and phase 2 detoxification and phase 3 detoxification. And then and only then you're thinking about ways to release these toxins from the fatty tissues and mobilize them. So bigger conversation than just, let's give some hormones, right? So then supplements to help with this. You'll notice some detox things, some oxidative stress things. Butylparaben. Parabens are ubiquitous in our environment. They are endocrine disruptors, and we need to manage them. So they mimic hormone function. That's what these parabens do, and it talks about the mechanism. So you've got the endocrine disruptor basically sitting in the hormone receptor site. The hormone can't do that, and this may have a bigger, depending on the toxin, may have a bigger affinity for this receptor or a smaller affinity for the receptor. But nonetheless, it's causing this hormone cascade. And then here's the list of other endocrine disruptors looking at perchlorate, glyphosate, which is Roundup, and all of these different things. BPA. BPA is, we know about BPA because it's labeled as BPA free in baby bottles and water bottles, but it's not BPA free in anything else. If it doesn't specifically say BPA free, I guarantee you it isn't BPA free. And even if it does say BPA free, if it has recycled plastic in it, what they should be saying is no BPA added, because the recycled plastic may well have BPA. And then we're going to talk about bone health on this test, right? So estrogens and androgens do different things to different cell types. And if it's not balanced properly, you get increased bone loss. So we're looking at DPD. DPD is a molecule that basically stiffens type 1 collagen, which is found in bone. And it's elevated. Now, this stuff is not elevated. So in the bottom line, this is a setup for bone loss. And then it talks about, what do you do? Well, here's those isoflavones again. Calcium is the obvious one. But also lactoferrin. RNase enriched lactoferrin inhibits osteoclast activity, reducing bone resorption and consequently lowering urinary DPD, which is a marker of collagen breakdown. So getting this stuff can be helpful. And then here is, I don't know why they do this, but up here they talk about soy isoflavones, which really includes genistein, but that's a specific one that you can get in health food stores. Okay, and then there's lots of suggestion. What do you do about this? Well, talks about lots of things to do nutrition-wise, right, or supplement-wise, ashwagandha, caffeine, all the things that we've been talking about, chromium picolinate. It's kind of a summary of everything we talked about in all of the commentaries. Endocrine disruptors, what are we going to do about it? All of these things. I think there's more important things to do for that, like a plant-forward ketogenic diet. Once you have all the other phases set up, that's how you mobilize the toxins. So lots of information here. And then as we get to the bottom of this, we saw the summary, and then this is just all the results without commentary. So here we have all of the stuff. We have this high cortisol. We have all the stuff we talked about in the context of a woman who has some postmenopausal symptoms, but also has heart disease and clots. So what are we going to do? We're going to just give her some hormones? There are people who will say, yes, we're going to do that. I'm not. I'm going to detoxify these endocrine disruptors. I am going to try to figure out how to optimally detoxify that 4-hydroxyestrone. And I'm going to optimize receptor sensitivity and try to get all this rebalanced. So how do we do that? Well, we do it basically with diet and lifestyle and stress management like we've done for this whole course. Remember that this course is the entire functional medicine matrix as seen through the lens of the center of the matrix, which is the mental, emotional, and spiritual domains. And that's what we're going to continue to do. All right. So I hope, and then again, this is just everything we already talked about, just without any commentary. So here's that high morning melatonin. Here's the atrazine and paraben and all the other endocrine disruptors that were normal. Here are the estrogens that we already talked about. The 2-hydroxy and 4-hydroxy, and the 4-hydroxy is the dangerous one, as we talked about. And it's clearly the most dominant, as you can see. There's a little elevation of 2-hydroxy, but look at these. These are really high. So that's how I think about this test. I think about it in total. And I think about the context of the individual that I'm looking at. I don't think about, oh, the estrogen is low, let's give some estrogen. I think about, oh, the estrogen, in this case, is high in the context of somebody who has heart disease and clots. That's not good. We need to help her figure out how to detoxify that estrogen better. We need to figure out how to get rid of that 4-hydroxyestrone pathway that's so dominant and shift it towards the 2 and the 16. We need to think about optimizing sensitivity of the receptors and things like that, rather than just knee-jerk reflexively giving hormones. So that's this whole test. Stop sharing, and thanks so much for your time. We'll talk next time.